Good evening. Thank you for joining us tonight for the AGA webinar on post-election lame duck, what this will mean for GI. I'm Carla Ginsberg, chair of the AGA Public Affairs and Advocacy Committee and a private practitioner in Newton, Massachusetts. After a contentious election, the status quo remains in Washington, D.C., with President Obama remaining in the White House, the Democrats retaining control of the Senate, and the Republicans retaining control in the House. But there is a lot of work to be done, even before the inauguration of new government officials in January. A budget battle of historic proportions faces Congress, including a staggering number of fiscal issues, such as fixing a 29% Medicare physician reimbursement cut that both political parties agreed to postpone until the post-election lame duck session of Congress. Time is running out, however, and the Congress must act soon to avert a serious fiscal crisis. But how will this affect you as a practicing gastroenterologist? To answer these questions, tonight we're going to hear from experts with Heart Health Strategies, a bipartisan consulting and lobbying firm specializing in legislative and regulatory healthcare issues and a longtime partner of the AGA. Tim Yale, a principal with Heart Health Strategies, is a Capitol Hill veteran logging 15 years of service with several prominent members of the House and Senate, and served a leadership role in several local and statewide political campaigns. Sue Rantham is a principal and vice president at Heart Health Strategies who's been with the firm since it began. Previously, she had worked on Capitol Hill for more than 12 years, handling healthcare legislation and shepherding many healthcare laws through the legislative implementation process. Tim and Sue will be discussing the current lame duck session of Congress and the pending effects of the fiscal cliff and sequestration on the practice of GI if Congress does not address the issues now. Then we will share the AGA's position on the issue of funding cuts and the advocacy efforts you can join us in to ensure gastroenterologists are being represented in Congress. All questions will be answered at the end of the webinar. To ask a question, please type the question in the question pane. Tim, can you please begin?
Thank you, Dr. Ginsberg. Good evening, everyone. My name is Tim Yale. My colleague, Sue Rantham, and I are very pleased to be part of this presentation on the post-election lame duck session and what all this means for you. Next slide, please. For this presentation, we will cover some big picture aspects of last Tuesday's election results and the changes that those results will bring to the next Congress. We will then take a look at the lame duck session, which started on Tuesday, and what we know so far. Then we will sharpen our focus on some of the more relevant policy discussions that will affect GI docs, such as the STR or sustainable growth rate, and then the issues that are collectively known as the fiscal cliff, and that deals with the budget cuts, the sequester, and the debt limit ceiling. Finally, we'll provide you with our thoughts on the future of the Affordable Care Act after all this. Next slide, please. Next slide, please. Thanks. In terms of Election Day, it seems we're picking up just about where we left off. In the White House, as all of you know, President Obama returns for a second term, nearly matching his 2008 electoral vote total, 332 to 206 over Mitt Romney, and gaining just over 50% of the popular vote. The Senate had a strong showing for the Democrats as well, thwarting odds makers and picking up 2 seats to increase its majority control to 55-45, including 2 independent senators, one from Vermont and one from Maine, who will caucus with the Democrats. The House, however, held the line for the GOP, and the Republicans really only lost a handful of seats. The majority control stays strong with Republicans there by a count of 233 to 196. There are still about 5 or 6 races yet to call, but even if all of those races went into the Democrats' favor, they would not gain control. So that stays in Republican hands. Next slide, please. Now, with all those changes, that means there are about 79 new members of the House and about 12 new members of the Senate, although half of those new members of the Senate are House members coming over from the House. But part of that domino effect of this turnover of the 2 chambers is also turnover in the committees of jurisdiction for health care. And there are 4 committees that hold health care jurisdiction in the Congress, 2 on the Senate side, 2 on the House side. There's Senate Finance, the Senate Health, Education, Labor, and Pensions, or Health Committee, House Energy and Commerce, and the Committee on Ways and Means. And on Senate Finance, there will be 4 new members. On Senate Health, there will be 1 new member. The House Energy and Commerce Committee will see 9 new members, and House Ways and Means will see 5 new members. So part of our initial lobbying outreach with the AGA is going to be to introduce ourselves to the incoming freshmen and sort of let them know about the AGA's federal agenda and what we're going to be looking for in terms of communications with them. Next slide, please. However, some of those new members will have a head start, as we see there are still about 19 to 21 positions elected or to be elected in the 113th Congress. Ironically, one of those not yet called seats, there's a position running. So we'll have about 21 doctors, and there'll be an array of specialties representatives you can see on the slide here. We think this is an important constituency to have in the Congress, as obviously healthcare still is a big part of what Congress is debating. And then we have found that these doctors who are now congressmen, some are senators, do play a large role and a large leadership role on healthcare issues, and we'll hope that trend will surely continue into the 113th Congress. Next slide. So Congress returns. As we mentioned, the current Congress returned to Washington on Tuesday, and the hallways are extra crowded because in addition to the current members who are returning for the lame duck, all of the new members I mentioned, the 79 members of the House and the 12 new members of the Senate, are also here for orientation. So it's quite an interesting time in Congress. We have both sort of, the current Congress and members of the new Congress occupying the chambers at the same time. This week they began organizing, picking leadership, and also holding hearings on some of the top issues of the day, such as the meningitis outbreak, and even the Petraeus scandal is getting a few hearings this week. But they're really, also meeting with their leaderships, and tomorrow many of them will meet with the President to talk about the sort of larger issues that we've been waiting since they adjourned to come back and deal with. Those issues are on the next slide. Next slide, please. Which would be the sustainable growth rate, again, the fiscal cliff issues, and the Bush tax cuts. Those will be sort of the main focus of the issues. Really starting a little bit this week. Next week they're going to be off for Thanksgiving, and then they'll come back on the 26th, the week of the 26th, and really begin to hammer out how they intend the 112th Congress to deal with these issues. Many of these issues, as Sue will discuss, they do have a ticking clock. We have until January 31st on the Bush tax cuts, the SGR, and even the sequester. So it'll be quite a rough ride once we get back to Thanksgiving, and some real hard decisions have to be made. Next slide. So at this point, I'm going to turn over to Sue to sort of take us further into discussions on the SGR and the fiscal cliff.
Thanks, Tim. Yes, I'll start with a closer look at the SGR, which is the sustainable growth rate. The SGR is part of the formula Medicare uses to pay doctors. Specifically, it was intended to address the growth or the volume in spending. In Congress, Democrats and Republicans agree it is a flawed formula, but it is the law, and it requires a change in law to fix it. So therefore, they need to find a way to pay for a change. Next slide, please. So we face a pay cut, a cliff, so to speak, on January 1st of more than 27% due to this formula. Each time that Congress temporarily stops this cut, which has been going on for about 10 years now that they've kicked the can down the road, it causes a bigger hole for them to dig out of. And that's because the formula continues to revert back to what it would have been without the fix. So it results in a larger cut each time. As Tim mentioned, the current cut is, or the deadline that Congress put in place for the legislation expires December 31st. So if Congress fails to act by that time, that's where the 27% cut would come in. Now, what you'll see on the slide is I pulled together the cost of what it is to fix it. If you were to instead change it to the Medicare Economic Index to allow the formula to grow in line with the Medicare Economic Index, it would cost nearly $400 billion. if you rebase it, which means essentially to keep the formula, the SGR formula, but start it from scratch again, so kind of fill in that hole, then it would be $254 billion. There are proposals out there now for a longer-term fix, but there's not yet consensus, not quite yet from the community and not from Congress. So those negotiations will continue. Could I have the next slide, please? So we've all likely heard the term fiscal cliff recently. And just to define what that means, it's really the more than $600 billion in federal spending cuts and tax increases that will automatically take effect next year if Congress does not act to avert that. So cuts of that magnitude will impact your practice. Next slide, please. So due to the deficit, Congress passed the Budget Control Act last year. And as a result, it put in place 2 stages of spending cuts. The first stage, which already went into effect, provides spending cuts to discretionary spending. In discretionary spending, there's basically 2 categories of federal spending, discretionary and mandatory. So the mandatory, or also the term entitlement, are things like Medicare and Medicaid that automatically are dispersed without an annual appropriation process. The other funding is termed discretionary spending, where Congress comes in each year and says this is how much money we're going to provide for different agency or program. So discretionary spending includes like NIH, public health programs, CDC, but also non-healthcare programs, transportation, agriculture, things like that. So in that first stage of cuts, it's a total of $841 billion over 10 years. $44 billion of those cuts already took place in fiscal year 12. We're now in the start of fiscal year 13. The second stage put in place a sequestration, and that was triggered if a super committee, which was a bipartisan group of House members and senators, who were supposed to negotiate a deficit deal. A year ago, they announced that they could not come to agreement, and as a result, that triggered what's known as a sequester. Next slide, please. So what sequestration is essentially is an automatic across-the-board cut. And if you exceed a target, spending is reduced proportionately to meet the target. Well, we did exceed our target because of the super committee failing to reach agreement. So what the result is $1.2 trillion in cuts, but this time it's both discretionary and mandatory or entitlement spending. So it's $109 billion per year, and it's split nearly half between defense spending and non-defense. Next slide, please. Now, there are some programs that are exempt from the sequester, and it includes the Veterans Programs, Medicaid, the Children's Health Insurance Fund, CHIP, and then also Medicare beneficiary cost sharing and premiums, which as a result will place more pressure on providers. Next slide. Because as I mentioned, physicians are not exempt, nor are the other providers. However, the cuts are limited to 2% per year, and that, you should know, compares to cuts of 8 and 10% for the other programs. So things like NIH are facing an 8% cut. Security or defense programs are facing 10%. Next slide. Now, the cuts are harsh because they were the motivation to come to agreement. The President has said, quote, the sequestration itself was never intended to be implemented. It was the hammer. However, now they have to use it unless they come up with something else. Next slide. The policies don't happen in a vacuum. The 2% cuts are bad enough on their own, but they're not the only cuts Congress has imposed on physicians. Next cut, or slide. cut. So what you are facing in the physician world is not only the impending SGR cut, which hopefully will again be averted, but also, as I mentioned, the sequester, which is looking at 2% cuts, and that's per year, so on top of each other. But the Affordable Care Act put in place other penalties. A number of them are for the quality reporting programs, so e-prescribing, the Physician Quality Reporting System, PQRS, the electronic health record, the value-based payment modifier, and then in addition, the Affordable Care Act created an independent payment advisory board known as IPAB. And that is a group of 15 individuals who would be appointed, not elected, and basically their job would be to make recommendations to reduce Medicare spending. Their charge would be very broad, and if Congress doesn't change their recommendations within a very short time after they would be made, they actually carry the power of law and would be implemented. So that provides a real unknown for what it could turn into. Next slide, please. So the sequester and the Budget Control Act are the result of the last time, could I have the next slide, please, that Congress negotiated to raise the debt limit. So therefore, they're going to have to revisit this because now our debt ceiling is $16.4 trillion, and we will default early next year. So we need to raise it again before the end of this year, and that will likely be the motivation for broader reform, spending, and tax negotiations. Next slide. Now the Affordable Care Act, as Congress looks at the spending, may revisit provisions from the Affordable Care Act. Speaker Boehner in the House recently acknowledged it is the law of the land. So repeal efforts likely will turn more to addressing particular concerns as the law is implemented. Next slide. Some of the issues that have been thrown out as possibilities to relook would be the subsidies, which the eligibility or the amount that an individual gets to buy insurance from an exchange. Medicaid, both the federal match that the states would get or the expansion population. There are a number of taxes that came with the law, and there is bipartisan support to look at repealing like the medical device tax, but also there's talk about maybe reducing some of the other taxes. And then the penalties. The law puts forward penalties on employers or individuals for not offering or not obtaining insurance. So really all of these things could be on the table in one form or another as they look at how to reduce spending and save money. So Dr. Ginsburg will speak to what this means for your community.
Well, thank you, Tim and Sue, for that informative presentation. It's hard to imagine how each of us is going to be affected by these massive cuts. As you've just heard, without congressional intervention, these massive cuts will greatly affect practice reimbursement. In this economy, these cuts will really be disastrous for medical practices. A drastic cut in income means that medical practices may struggle to pay staff, provide benefits, and invest in the infrastructure required to participate in government quality improvement programs discussed this evening. Congress must take action to ensure that patients have access to the quality care they deserve and that physician practices remain viable for their communities. Next slide, please. So what is AGA doing? AGA can be found on Capitol Hill every day of the week advocating for issues of importance to GI, the practice of medicine and patient care. Through the AGA PAC, our voice is being heard. Actually, in this most recent election cycle, AGA PAC had a 95% win rate. And what does this mean? Of the 56 campaigns to which we donated, omitting the 2 undecided, 53 campaigns won. That means that 53 advocates for GI and the practice of medicine, in addition to many others, are in Congress fighting for issues of importance to us and our patients. Next slide, please. Given the current state of the fiscal cliff, we also do need your help. Please join us to call on Congress to take action to ensure fair reimbursement. So mark your calendar for Tuesday, December 4th, to be part of the first ever AGA virtual advocacy campaign. You can join gastroenterologists from across the country and flood Congress with phone calls during the lame duck session. We must tell lawmakers to protect patient access to quality medicine and avert a serious fiscal crisis. We need your help, so please learn more about how to contact your lawmakers and urge your colleagues to join us in our fight. And for more information, you can visit our website, gastro.org/stopthecut. Now, we have a few minutes to take some questions. As a reminder, if you have a question, please type it in the question pane, and it will be answered in turn. And if we can't get to all of the questions, we will post a Q&A online.
And we have a first question. Given the inability of the supercommittee to reach agreement and the status quo with the divided government, does this give IPAB more legs and weaken the possibility of trying to repeal this body?
This is Sue. I can take that question. IPAB, again, is the Independent Payment Advisory Board, and the election resulted in Senate Democrats gaining more seats. This particular provision was authored by Senate Democrats, and House Democrats, in fact, did not include it in their bill that passed the House. And some of their key chairmen on the health committees spoke out against it and felt that it was something that they, as chairmen, were supposed to do, is look at the Medicare program and make those decisions rather than handing them off to someone else. So with more Senate Democrats and a Republican House, it definitely is at odds. And probably more important than ever that we look long-term at Medicare reforms so that it would not trigger the IPAB going into effect. Because what I did not mention earlier in my presentation is the recommendations that it makes are triggered when spending exceeds a target. So if the spending stays within those targets, the IPAB would not be called on at all.
Thank you. And we have another question on IPAB as well. And the question is, who is the IPAB accountable to if they are unelected officials? And who are they, and what are their credentials?
That's a very good question. Who are they? There is in law broad categories of who these individuals will be. Notably, it does not include practicing physicians. It does include physicians in the mix, and it makes sure that there would be at least a couple. However, there's another clause in the language that you're not allowed to hold any other job. So that would, it's a little unclear who those people will be, but they're not going to be practicing physicians because you would have to give up your job. So who they are accountable to was the other part of the question. And this has been a debate. Congress receives the recommendations, and Congress can change them. For example, if it makes a recommendation, make it easy and say for $100 million that it's going to reduce Medicare spending, Congress would have a short amount of time that it would be required to act to come up with that same amount of savings. If they failed to, that is when it would have the power of law and be able to go into effect. So who they're accountable to, certainly not the voters. They don't really have anybody over them, but Congress, if they were to come in and change it, could, as long as it was in a relatively short amount of time that's prescribed in the law. And I think we all are concerned that Congress doesn't act in a very timely manner on anything.
More than that, I think Sue is absolutely right. And more than, for that separate set of savings to come up, there has to be a 60-vote threshold in the Senate, which is anybody who picks up the paper and realizes getting 60 votes in the Senate for anything is quite difficult. So I think the big concern with IPAB is that it almost, will be an automatic pilot once the IPAB panel sets it up and sends it to Congress if it is triggered. I get a lot of questions. Well, then, what if the Senate doesn't approve members of the IPAB, and so what happens if there's no IPAB board? Well, in the law right now, then the Secretary of HHS can act as the IPAB individually. So it is a very powerful tool for the executive, and we'll really only be accountable to the executive with virtually little input from Congress if they don't come up with a separate set of savings and can pass it by 2/3 vote in the Senate and the House. So it's a very troubling entity. Again, as Sue said, it was a creature of the Senate, not the House. There are many House Democrats who don't like it, but with an increased majority in the Senate among the Democrats, I think the days of IPAB repeal are going to be hard to come by, just by virtue of the raw numbers in the House and the fact that the President is on the hunt for more budget cuts.
And the other thing we should mention is that the IPAB, this current Congress, the repeal of it passed the House. And I had mentioned before it was a bipartisan support on the bill to repeal, but it won't really get anywhere in the Senate unless it can have 60 votes. As Tim mentioned, that's what avoids a filibuster to allow legislation to move forward in the Senate. In addition, with President Obama in office, I mean, this is his bill, this is his provision. He's not going to be willing to sign a repeal. So that's why the election makes it particularly difficult.
And the next question we have, since President Obama won re-election and the Democrats increased their majority in the Senate, will there be any efforts by House Republicans or other members to revise any of the physician mandates that were in the Affordable Care Act, or is there general bipartisan support to move physicians to a more value-based payment system?
Well, the value-based payment system in particular really started with the Republicans. And so that has been a bipartisan effort. And there may be movement to revise some of these things, but the general support is there. So I don't expect that, regardless of who's in office, that would change. I think they'll continue to push forward on that.
Okay, thank you. We have a question regarding the SGR cuts. And the question is that we have been threatened by these steep cuts in the past, and what is the likelihood that the 27% cut will go through this time?
I agree. I think that no one in Congress wants to see those cuts go through. And in fact, when AGA is on the Hill, and many of your physicians who have been participating in fly-ins on Capitol Hill and go visit with offices, you pretty much uniformly hear, Democrat or Republican, the message is the same. We agree with you. It's a completely flawed system. We want to get rid of it too. They've been having to talk about it for 10 years. We all have been having to talk about it for 10 years. They want to fix it. The big problem is what gets us to a permanent fix to get rid of this formula. And this formula came into place to replace a previous formula that everybody tried to change as well. So it's just not easy to pay for. The final fix is really the challenge. As Congress is dealing with these bigger budget issues, it really is on the table as part of it all, and they're very aware they need to fix this. So no, I don't expect any cut in January, but how long is the reprieve, I think, is the big question. And right now, part of the discussion is looking at possibly a one-year fix. We also have, there's 13 appropriation bills, and that's the process that puts money out to all of the federal spending and keeps the government from shutting down. And because they could not get those bills done on time, they wrapped them together and did what's called a continuing resolution. and that deadline was pushed off, so spending money is there until the end of March, basically. So a lot of these issues, they keep kicking off, and they have to negotiate and come back to them. So I guess a long answer to say, no, I don't expect it in January, but I don't know how long they'll put it off for. And I would just mention that if they miss their deadlines, which they have in the past, and I'm sure those of you who practice remember when they last did, because it means resubmitting your claims, it's a complicated process when they miss the deadline.
And just to echo what Sue is saying, I would agree. I don't think they'll let a cut go through. But there is opportunity here when they are moving such big budget numbers to include, a longer SGR rebate or fix than they might typically have individually. Moving a $380 billion pay for it is kind of tricky, moving it individually. But if you're talking about big budget reforms or a big fiscal cliff deal dealing with hundreds of billions, if not trillions of dollars, there could be an opportunity there for Congress to make a longer statement on SGR. Cynically, I don't know if they'll get to it, in December, given there's not much time to do it. But I think the next phase of this debate is, fixing this formula once and for all, because we have been down this road many, many times, as everybody on the call knows. And I think with the growth of the physician population in Congress, and even non-physicians who are advocates and becoming experts in this area, there are some legislative proposals out there now, sort of, making the rounds in committees and with members, and I'm hopeful that part of the 113th congressional agenda will be looking at a longer-term SGR fix.
And we have another question along those same lines. If Congress and the President enter into negotiations on a quote-unquote grand bargain, will a long-term solution to the SGR be part of those discussions, and how realistic is it to think that the SGR will be addressed with the larger issue of Medicare reform?
It's a tricky question. I know that when they're looking at reform, part of what the Democrats like to go for are really more, cuts to providers more than cuts to benefits, as you've seen with, the current, the current health care law. I have not heard the SGR individually itself come up in sort of the litany of things to deal with in the grand bargain. I think Leader Cantor and Speaker Boehner have raised it as an issue. But on the Democratic side, I've not heard too much serious talk about, an SGR reform. The last time I really heard it on the Democratic side was during the super committee, and I know that the chairwoman of that committee, Patty Murray, and the chairman of the House, Jim Henson, had talked about some SGR reform using a big budget movement, to fix SGR. But in terms of coming up this month, I would be surprised if it's in there. But we're advocating for it. We're making the rounds and letting them know this should be part of the deal, because this is a big budget number to move. And honestly, if you're looking at honest budget numbers, everybody knows the SGR cut won't go through, even though they account for it in their budget. And we come back at the end of every year, and we stave off the cut. So if you really want to talk about honest budgeting, the argument is, get an honest repayment system in there, and then this flawed formula that everybody knows will not be fully carved in. So we'll keep an eye out for it, because I would agree with the questioner that it is part of honest budgeting is to sort of solve this SGR question once and for all.
Thank you. And as a reminder, if you have a question, please type it in the question pane, and it will be answered in turn. And if we can't get to all the questions, we'll post a Q&A online.
Well, thank you
and that's
so much.
Question.
Thank you so much for joining us this evening for this AGA webinar on post-election lame duck, what this will mean for GI. Please continue to read AGA eDigest and the AGA Washington Insider Policy blog for more information about the first ever AGA virtual advocacy campaign. It's going to take all of us working together to reach out to Congress to tell them to stop the cuts. If you are interested in the effects of the fiscal cliff on research funding, please join us at noon Eastern Time tomorrow as my colleague Timothy Wang, Chair of the AGA Institute Research Policy Committee, for a webinar during which you will learn about the effect of sequestration on research funding and the outlook for federal agencies, including the NIH, the CDC, the Department of Defense, the Veterans Administration, and the Agency for Healthcare Research and Quality. And to register for the research webinar or to learn more about the AGA's advocacy efforts and to listen to the archive presentation, please visit our website at gastro.org. Thank you all very much.